Okay, all right. Our next speaker is Dr. Shahabuddin from the HMC, Peshawar.
Bismillahirrahmanirrahim. Hello everybody and good afternoon. I'm Dr. Mohammad Shahabuddin Khalil, SPR International Cardiology, Hayatabad Medical Complex. The topic of my presentation is out of the frying pan into the fire. I will start with case presentation. My patient was a 60-year-old hypertensive and diabetic male patient who had an inferior wall MI for which he was thrombolized in a periphery, and now he presented to us with a post-MI angina of class 3. On examination, the patient was hemodynamically stable, having a pulse rate of 78 beats per minute with a blood pressure of 130 by 80 millimeter of mercury. Chest was clear bilaterally, and cardiovascular examination showed normal first and second heart sounds with no added sounds and murmurs. His routine labs were sent, and all the labs were within normal limit, except for the drops which were raised. And this was his ECG. We can see that there are ST wave changes in the interior and inferior lateral leads. So since the patient was post-MI and he presented with post-MI angina with raised drop, so it was decided to take him to the cath lab and do coronary angiography. And during coronary angiography, right radial approach was taken, and the diagnostic Tiger 2 catheter got kinked in the brachial artery. So, and with further manipulation of the Tiger 2, it was followed by complete fracture, and the fracture part was extending from the brachial artery to the arch of the aorta. So, from a simple procedure like coronary angiography, we ended into an emergency, and at this time we were thinking what to do next for this patient. This is a fluoro loop. We can see that this TRIC 2 catheter has got kinked at the level of the brachial artery, and with further manipulation it got completely fractured. So can anybody comment at this level what could be the cause and how we can prevent this phenomena?
ऑडियंस में पीजेस जो हैं वो प्लीज कमेंट करें इस
अभी ये और किसने देखा है ऐसा कभी? हैज एनीबडी? या आप बताइए आपके साथ क्या हुआ था? बिकॉज थिंग्स कैन हैपन टू एवरीवन, और हर एक के साथ डिफरेंट अप्रोच होती है और डिफरेंट कॉज होता है, तो ज़रा बताइए प्लीज़, लेट्स शेयर दैट.
बेसिकली आवाज़ आ रही है ठीक. Okay, because the TIG catheter, it needs manipulation for engagement. So for the same reason, because there was a big curve which was attaching the brachiocephalic with the aorta. Sir, in
location क्या थी kinking की?
Subclavian to brachiocephalic area. From subclavian artery to brachiocephalic. It was there where it was kinked, because there was a loop at there, and TIG was taken, and it was not getting engaged in the coronaries. So again and again talk was given.
नहीं, मेरा सवाल ये है कि किंक की लोकेशन क्या थी? जहाँ से किंक हुआ वो किस जगह? इनका जैसे ब्रेकियल आर्टरी में हुआ ना?
Sir, it was junction of subclavian with the brachiocephalic artery. ऊपर.
ज़्यादा कॉमन साइट यही है इसकी ना?
सर एग्जैक्टली.
और किसी के साथ हुआ कभी? ओके, इसकी प्रिवेंशन का क्या? हाँ, आप अपना फिनिश करो.
So one of the reason is excessive manipulation of the this TEC 2 catheter, and the other reason for that could be possible vessel tortuosity. So with further manipulation, it got complete fracture, and we were thinking how to further to retrieve this a fractured segment of the catheter because it was extending from the brachial artery up to the arch of the aorta. So possible treatment we thought at that time could be we can pass a simple PCI wire and have a loop around it and form a helix and then could retrieve. We tried it from the right radial approach, but we were not successful. Then we thought we should shift our insertion. So we went to the right femoral approach, and from right femoral approach at that time in the cath lab we were having this multi-loop snare, which is usually a coronary artery snare. It is smaller in size, but we tried with that initially. But we know that the diameter of the aorta is so much that sometimes you don't get too much support, and so initially we were not successful. Then after that we thought we should take something which could give us much support, and then we took a Mullen sheath and extending the Mullen sheath up to the arch of aorta and to the ascending aorta. Like a mother-child technique, the catheter of that multi-loop snare was into the Mullen sheath, and we tried to hold the distal tip of this fracture fragment of the Type 2 catheter. And after hard work of 30 to 40 minutes, we were successful to hold the distal tip, and we were able to bring it to the tip of the Mullen sheath. And then it was successfully retrieved. The whole assembly was then removed. During the procedure, the patient was hemodynamically stable. He was not having any symptoms, but the surgeon on-call team was taken on board, and they were ready in case of any emergency. The patient was kept for 24 hours under observation, and the next day echo and everything was normal. Then he was discharged home. Patient had PCI of the LAD in the same setting, and then he was discharged home, and after 1 month the patient was again reviewed, and he was okay. So I have 3 take-home messages from my case. One is that coronary angiography is not always simple, and we should take each and every case as a challenge, and always be ready to tackle any kind of emergency. With this, I came to the end of my presentation. Thank you.
Sir, any comment on that? Basically, इसमें एक चीज़ का ख्याल करें, whenever you are taking a catheter, आपके टेक्नीशियन से किसी वजह से वो एक्सीडेंटली बेंड हो जाता है, be careful about those things. Number 2, when you are manipulating, रेडियल का मेरा एक आदत बन गई है कि अगर मैनिपुलेशन ज़्यादा चाहिए होता है तो आई कीप द वायर इन, आई पास द वायर, उस पर मैनिपुलेट करता हूँ. और फिर लेकिन कॉशन इज़ जब वायर आप निकालें तो लेट द ब्लड कम आउट, क्योंकि उसमें एयर रह जाती है. तो दैट वे मेरा ख्याल है जब से मैंने ये टेक्निक शुरू किया, आई हैव नॉट हैड वन, लेकिन पहले मेरे साथ भी हो चुका है ऐसा. तो दीज आर फ्यू थिंग्स यू कैन थिंक ऑफ, लेकिन दीज थिंग्स कैन हैपन टू एनी वन.
This catheter kinking, one is manufacturing fault. When we are taking the catheter, sometimes in primary PCI we are in hurry to take and don't check about, but we should check whether there's any manufacturing fault, whether it's pre-operative or pre-procedure kinking or not. And when you are manipulating the catheter, just check the monitor whether pressures are there or not. If pressure line is flat, then there is some issue, and we should manage it. And the good point sir added from his experience that manipulation with wire is good support to engage any artery as compared without manipulating without the wire. Thank you.
Thank you, Dr. Bashir, Dr. Mansoor, Shahabuddin. So takeaway message is intervention is not an easy game. So to doing angiogram, we are thinking the simple, but it's not a simple. We can trap anywhere.